agenda for today's meeting. I do already have an amendment to make under item 7, the oath of office. We would like to move that, please, into new business. And if I can have a motion and a second to move that agenda item.
So moved, Leanne.
Thank you, Leanne.
Here's Linda, a second.
Thank you, Linda. All those in favor of the agenda with the amendments? All right, so we will move forward. Thank you all. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and appearance of conflict. Our second action today is to review and vote on the January 2024 meeting minutes. Those are in your packet that Krista sent last week. And reminding everyone, this was our first in-person meeting of 2024, and it was very nice to see you all. Is there a motion and a second to approve the meeting minutes from January 2024? Thank you, Jacqueline.
Second, Elizabeth.
Thank you, Elizabeth. All those in favor?
Aye.
Any opposed? All right, thank you. The board minutes are approved. We are moving on to the fourth agenda item with program committee updates and summaries. And we will begin with the Health Committee. And Dick, we're turning it over to you.
This is such a hard job, but I will try my best to summarize an outstanding 45-minute presentation by Dr. Shukla, who since August has been a consultant for the county in addiction medicine. And he gave a great talk about smoking supply distribution for harm reduction, because we might be familiar that the county provides intravenous supply distribution for harm reduction. And he eloquently went through advantages of smoking supply distribution for people like myself who didn't know much about this subject. And to briefly summarize some of the advantages, it's to reduce transmission risk of disease, to reduce the risk of overdose with smoking, and reduce the risk of becoming addicted to drugs via smoking versus intravenous. And then it was, he actually talked about a most interesting, I suspect it's a fact and not an observation, that there are disparities in drug use by race. And because our county does have an intravenous treatment harms reduction, and whites use intravenous drugs as the largest racial proportionary group, and since smoke drugs are usually performed by the Black population or Black individuals, disproportionately higher than other racial groups, that he's suggesting a pilot project with Buncombe County Department of Health and Human Services for 3 months, which would cost an average of $500 a month or $1,500. And he was looking for our feedback because he had an outstanding presentation of how it would work. He was looking for our feedback from the subcommittee, which we're going to discuss next month. He's looking for feedback on the board. That's everyone here and those who aren't. So we were going to supply information with his PowerPoint presentation and our opinions. And we were informed that all the suggestions are weighed by our county managers, and the ultimate decision is made by them. And so that's my summary.
Thanks, Dick. This is Ellis Matheson, Public Health Director on the Health Committee. So Dr. Shukla did give us a great presentation. I have the PowerPoint, which we can have sent out to the entire board so that you can review it. But yes, we are looking for thoughts, feedback around doing a pilot within our syringe services program, of course, to reduce harm and make sure that we are equitably providing supplies within that program. And within that pilot period, of course, collecting data to identify, hopefully it might also reduce syringe trash, I guess, as some people might say, as well as clearly, hopefully preventing disease transmission. And he also talked about how smoking sometimes can reduce or help someone not reach full addiction as quickly as intravenous use. And so, well, of course, we don't want people addicted to drugs. This is a way to help reduce that harm. I did not say that very eloquently, but so we will send out that PowerPoint for you to review. And like Dick said, we will have more discussion in the Health Committee at the next month, and then also can ask the larger board for any feedback before we implement a pilot program. And then, of course, would come back with you with results from that pilot.
Are there any questions for Dick or Ellis?
I know you said we discussed it further, but I sort of got a little bit confused. If someone is smoking, could you repeat that part, that they may have a less capacity for?
Yes. I think Alice and I referred to the fact that if you look at people who are doing drugs intravenous versus doing drugs smoking, that an advantage of smoking drugs is there's a lower risk of overdose.
Oh, okay.
And there is a lower risk of becoming addicted. Both of those were unknown to the unaware me. I had no idea. So I'm throwing it out there thinking that this is great. And that's why I mentioned that as a significant advantage.
I just got a little confused.
Sorry. I just wanted to jump in because a very well publicized MMWR came out last week from the CDC that indicated a higher risk of overdose deaths with smoking versus intravenous use. Some of that could be because smoking is more popular, but with a cause of death identified or with a method of use identified, 23% of overdose deaths, 23% of overdose deaths, I'm suffering here, were from related to smoking, only 16% after intravenous use. So I agree with the harm reduction from the disease transmission perspective. I'm not sure there's total clarity that it's much safer in terms of overdose, at least according to an MMWR that came out on February 15th.
It would seem to also be relative to what you're smoking. So there's several different drugs that can be smoked. So it seems as though it would depend on the smoked drug, because some have different, I don't know if what the right word is, capacities for addiction, levels of strength. So anyway, It just needs to have more specifics because the percentages doesn't, for me, it doesn't tell me how to understand that.
Yeah, Jacqueline, that's a great point. And yeah, there's many variables that go into that, but I think the main thing that we really want to focus on is reducing harm and making sure that we're providing supplies equitably. Those would be the two big things. And thank you, Steve. I was going to ask you if you had a link to that MMWR because I have not seen that, so I will certainly review that as well.
Well, is that
As a
something
member-
to Dr. Shukla?
Say again?
Is that an article to send to Dr. Shukla to have him defend himself?
Yeah, I certainly will make sure that he's seen that.
Well, not so much to defend himself, but to be able, like, to reconcile, to be able to reconcile the two. I think that he, you know, this is his turf, so to be able, if he's coming back in March to the committee at large, to be able to reconcile these findings from the data that he shared with us earlier today.
Yeah. I'm not trying to throw
As-
in a gotcha here. This is just one
Mhm.
study,
Yeah.
so needs context.
As a member of the
Brenda?
committee, can I throw in a comment? This was mostly new information to me. Addiction has never been my area of expertise by any stretch of the imagination. So much of it was new and pretty intense for me. The committee did not have an opportunity to discuss it. His presentation pretty much took up our whole time. So the committee has not had a chance to discuss the fine points of addiction or any of the issues. So I think our plan is to talk about it in our committee meeting next month. So I personally will have had an opportunity to do a little reading on this before it comes up again for discussion next month. So a lot of the questions that are coming up now in the comments, I'm making some notes to follow up on them. But it was an interesting presentation and as I said, new information for me. So I just want to kind of throw that out for the rest of the group that we probably all need a little bit of time to digest this information.
I will say
Hey,
that I had the benefit of a presentation from Dr. Shukla in the last, I guess it was Saturday, actually. Buncombe County has started a group of Black elders in the community. I don't know if anyone knows about that, and I'm part of it. I know you can't tell, but I'm an elder. And Shukla presented this weekend, and so I feel like you did, but we had the opportunity to ask questions because we didn't combine it. Well, we did actually have another agenda, but we just decided to toss it so we could continue to hear and ask questions because it got so much interest. And so the fact that you are providing that resource for community people as well was just phenomenal. Everybody learned a lot and had their own stories to share. So I just wanted to share that is a resource that is valuable.
Thank you, Jacqueline. A question about process. Did I hear you correctly? Or let me just ask for clarification. Will the process be that Dr. Shukla returns to the committee meeting next month? And is there going to be a presentation at our board meeting next month? And then do the commissioners vote on this, or is it the county managers?
This is Ellis. I'll jump in, sorry. So the process is, yes, we're inviting Dr. Shukla back to the committee to process the information, have discussion. If the board would like that to come to the whole board, that we can certainly arrange that. Since this is a pilot program, this does not need to go to the county commissioners, because of course we implement pilot programs all the time. And it's the way we're going to do this pilot, it will be budget neutral. So we won't be requesting any money to implement this pilot program. But we did feel like strong enough that it was important that the board was aware, and just to bring this to your attention and receive any feedback that you all would like to for us to have in moving forward with potentially implementing this pilot. And of course, then at the end of the pilot, we would report out as well.
Yeah, but can I add that my impression was that we were going to have our subcommittee meeting next week, and at a future date, we would get it on the board agenda, so that we would discuss it at the board level too.
Yeah, and I think that's totally fine. If we would like to make this an agenda item for the full board next month, we can certainly do that if that's what the board would like to do.
Or the month
Well, I
after.
would. Yeah, I
might
guess.
suggest-
Yes, go ahead.
I'm sorry that I'm having some connectivity issues, so forgive me if my camera comes in and out. I think just to honor our committee structure, what I might suggest is what Dick said there, is that the committee got the information today, that next month they vet the information and then bring a recommendation to staff and the board, maybe at the April meeting. Like Ellis said, we don't all obviously bring every program we're implementing to the board. That would take, we'd have to meet more than once a month. But I think this is a kind of cutting edge, and we want the board to be a part of this decision in your advisory role before we move forward. I think there's, we lead in a lot of ways in Buncombe, and I think it would be important that we hear from our board and have your support on a program like this before we begin to pilot it. But I do want to honor the committee, because I'm understanding the committee hasn't really had a chance to discuss it yet. You just got the information today. And I know that sounds a little bit slower, but I think it would still give us plenty of time. Ellis, correct me if I'm wrong, to get started timely if we wanted to move forward.
Yes, that will be absolutely fine.
Well, thank you, Dick and Ellis, for the summary. And next we will hear from Dan and the Safety Committee.
Good afternoon. We had a really great presentation looking at data, racial equity data. So this is something that Rebecca and her team have been working on, creating a really robust data dashboard of outcomes and intakes and dispositions of kids coming in to DSS and foster care. This is something, one of the things that I would say first off is I believe, and Rebecca, you can correct me and clarify, but this is something that Rebecca and her department has been undertaking with some guidance outside the department, but really inside her department, and creating these data dashboards to really understand based on race and ethnicity of what's happening, so that improvements can be made, part of her broader framework around trauma-informed care, and making sure that everything they're doing is with a racial equity lens. So I really applaud the work that Rebecca has been leading within her team, and this data dashboard is phenomenal. I mean, they have really developed an amazingly robust way of looking at what is happening with the kids coming in by race and ethnicity and over a 3-year time period. Not unsurprising that there are some issues that bring up questions. And so one thing that we our next steps is we have data now, and now we have to look at what's driving the data, understand the data a little bit more. You can't assume or draw conclusions just from one data set. And so this provides now the information to ask more questions and to dig in so that improvements can be made where they need to be made. And so I really am so impressed that this data has been driven. And so our next steps are actually to debrief about this and kind of start to ask the right questions so that more information can be gathered as we move forward this year. So this is a huge thing. I think this is one of the that we can say that our proclamation that we did 2 years ago, I believe, on prioritizing 3 years ago, has it been, Lucy? So on calling racism a public health crisis, one of the big action points was to create data dashboards so that we could understand this and follow this. Rebecca has now done it in DSS. So it's really, really powerful to do. So we didn't have much time to talk about it. So we're going to be talking about that next time as we digest it and debrief about it and give guidance on what next steps might be to look at the stories behind the data. Rebecca, any other committee members, other comments?
I think you captured it wonderfully, Dr. Frayne. So thank you for that. And yeah, just really excited to be at this place. And one thing we mentioned is that we've kind of met with each of our leadership teams across the continuum of our services to say, like, this is the data, this is what it says, it's not all good. What do we start to do about it? So everyone's starting to think about what is that underlying piece and how do we have some really concrete, tangible action steps to try to work toward equity in our system. So it's a really exciting time.
I think this would be something valuable once we, again, using the committee structure. I think this is perfect. As in the last discussion about committees, is that we will debrief it and talk about it. And I think it would be valuable once we understand a little bit more on the questions that we want to ask to bring it to the full board. So everybody's aware of kind of some of the key elements of the data and some of the things we're recommending moving forward in the next year. So for a future full board meetings to have a discussion about once we digest it a little bit more. Lucy, you're on mute.
There you go. Thank you, Dan. Jacqueline gave a thumbs up, and I was saying I give 3 thumbs up to this work. And Rebecca and Dan, I am grateful for your leadership with this, and I think this is setting the precedent for all of the departments within Health and Human Services. Thank you. We now, I don't see Martha Salyers here. So Philip, I'm wondering if you can provide us a summary of the Opportunities Committee meeting.
Sure. We're a small group today. Just talked about a couple quick things. We talked a little bit about Medicaid expansion and where we are with that. And I'll just give you some numbers. I think that gives a little context of how expansion's rolling out in Buncombe County. In December of 22, we took 2,500 Medicaid applications in Buncombe. In December of 23, when expansion rolled out, this past December, we took 6,800 Medicaid applications. So about, almost 3-fold increase. January of 23, January a year ago, we took 1,800 applications. Last month, we took 3,700 applications. But as you can see, it's starting to come down. In February of 23, we only took 1,400 applications. In February 24, so far this month, we've taken 1,900. So it's starting to tamp down a little bit. And I did update the committee that we have a report card every month that we have to pass as far as processing applications timely. We probably will fail for the first time ever in February of this year. We have about 4,000 pending Medicaid applications right now that we're sitting on, which is usual. It's about 800. So we also talked about the energy program a little bit. I know Kelly's going to do a presentation of our preparation for next year in the energy program. And we talked a little bit about our call center struggles and that we're on track. We took 130,000 calls last year in our call center. This year, we're on track to take about 200,000 calls. And it's been a struggle for our staff. We're dropping about 1 in 4 calls, whereas we used to drop about 3%. And then we talked just a little bit about remote work and the structure of how the division works within a hybrid work model. Anything else I missed, Savannah or Leanne?
So sorry. Yes.
Yes. Go ahead, Savannah, and then I see Dan's hand up.
Dan, go ahead first.
So I was just going to ask a question of your team and Philip, is this backlog and this drop call rates, is this something that you expect to resolve soon? Is this just a quick problem that is going to resolve itself? Or is this, you foresee this as a long-term problem that's going to take a long-term solution?
I will say, I believe it's a long-term problem. And the long-term solutions, we have asked for 3 call center staff in our budget for the coming year. I mean, the bottom line for us is we just don't have enough bodies. The other thing I'll say is we've looked at, Sony, I've had some conversations with a company about an AI solution that could possibly help at least with the basic calls. What I'll say is that our call center is a little bit different. They don't just answer the phone. They're actually caseworkers. And they do work in the call center, meaning that if somebody just wanted an address change or something like that on their food case or their Medicaid or whatever, that's handled by our call center staff and not the individual's caseworker. So, you know, the average length of time that a call center staff is on a call with an individual is about 3 minutes or so. But I think it's a long-term thing. I mean, by the time we're all said and done, I think with expansion, we'll have almost 75,000 or so Medicaid recipients in Buncombe County, somewhere between 75 and 80,000. That's a lot of calls, and our food caseload's up. We have 40,000 food recipients. It's just a volume issue for us right now, and I don't think it'll go away.
Mm-hmm. And wasn't some other entities handling some of this, and then you had to take it all? Seems like you reported that at the last meeting.
The energy program, and I think Kelly's going to do a presentation on.
Okay.
Mm-hmm. We brought that back in house, but actually those calls are going to Kelly's team right now. But once energy comes to my division in July, we'll have to navigate those calls too. And you know, I think Evelyn served about 6,000 people last year. Mm-hmm. I think we'll serve 10,000 energy. Mm. It's just, I mean, we serve over 100,000 residents within our division each year, and you know, when you see almost like a 70% increase in call volume, it just shows to the amount of people who are receiving services through us.
Go ahead, Dick.
Yeah, I had a question about applications for Medicaid expansion. And I had recently checked the dashboard, and our county's keeping up with the rest of the state. Both the county and the state have signed up approximately 50% of the estimates for those individuals who would be eligible for Medicaid expansion. But when I did the calculations, it looks like it's going to take a minimum of 6 months to sign everybody else up. And I didn't know if there were any short-term solutions to hasten that process, or if we just have to wait the 6 to 8 months.
Well, with all of our services dependent upon people applying, and there will be people, I think the state estimated that we probably would not reach that estimate that they gave us of 15,500 for anywhere from 12 to 18 months. So it just so happens that we had a huge influx, and I think that that's a reflection on the county and the job that we did trying to promote expansion. What I'll tell you is I've looked at the numbers across other counties across the state, and you're right. I think we're somewhere about middle ground. There's some counties that really haven't increased their caseload at all and not taking a lot of applications. Then there's other counties that are in worse shape than we are. So it's kind of runs the gamut, I guess. And my guess is some of that depends on how well they promoted expansion as a program and available to folks.
Thank you, Philip, so much. Oh,
how
go ahead,
soon-
Savannah. Sorry.
Okay, great. I forgot to ask you this question when we were together earlier, Philip. We talked about how the straight through processing that the state is going to start is really going to help you guys out. That just started? Like, when will we know how effective it is at straight through processing?
Well, it's been, we've done it on regular cases for applications who applied online for probably about 6 to 9 months now. Now, only about the last time I looked, we only had about 8% of the cases when people applied online actually went straight through, meaning that a caseworker didn't have to touch it. That the system took the information the person put in, it determined their eligibility, and gave them Medicaid without a caseworker having to touch it. That's a great thing. But, if you can up that percentage to say 25, 30%, that'd be like gaining a lot of staff. What we talked about, I think the state actually joined the federal marketplace. So what happens is that now when people apply for health insurance on the open marketplace, if the system determines they're eligible for Medicaid, it will possibly straight through process that case. So I can go out on healthcare.gov and apply for subsidized health insurance. And if that system determines that I'm eligible for Medicaid and it sees no red flags, it will automatically put that individual on Medicaid without even having to purchase health insurance.
Amazing.
That's a great thing.
But do you think that that'll probably be like next year this time, by the time that helps you? Yeah.
Probably.
Okay.
Probably becomes a big thing during open enrollment next year. It will help some this year because, people can apply for insurance through the marketplace anytime during the year if they've had some kind of change in situation, like if you lost a job or something like that. You can apply anytime, or you had a child.
Could we put a message on the call center that says go apply at the state for that? Because they're all adults we're talking about, right?
Or they're applying for their children. But it doesn't matter. I mean, their children may be eligible through that also. I mean, not just adults. I mean, it could actually be, if I'm applying for my family, it could be that maybe the adult didn't get, they has to purchase their insurance, but their kids get Medicaid. So
Yep.
I don't know. I've never really thought about that. That's probably a good point. And let's take a look. We'll
Yeah.
take a look at that. I that's probably not a bad idea.
Cool.
Thank you so much, Philip. We move next to the energy programs update with Kelly.
Well, hey there, everyone. So just want to give you an update about the energy program. We, just as a reference, the contractor that we had stepped back from that, and effective December 1st, we completely took that program over. We did actually start working towards taking it over slowly but surely in November. So there was a little bit of a crossover there, just so you know. Wanted to let you know, though, that I have done comparison data to be able to say this is what we've done, this is what we haven't done. So the months that Eblin had it, which was July through November, they were able to deliver a total of $293,484.80 in the SIP program, which is a crisis intervention program. That means that you have to be in danger of or have received disconnection for your heating source or your cooling source. Typically electricity, but of course we do have a lot here that heat with fuel oil, natural gas, things like that, propane. And so once Buncombe County took it over, since we've taken it over, in SIP dollars, we have delivered $496,854.11. And with the LEAP, we have delivered $893,300 so far. That is just through the end of January. In comparison, those same numbers last year, with our partner, they had delivered a total of $388,570 in SIP and $747,100 in LEAP. So just as a comparison to see, we are actually beating what our partner was able to do last year. There's a plethora of reasons for that. One of the things that I can tell you, though, is that in the month of January, when, and just so everyone's on the same page, SIP basically runs year round. So it goes from July 1 to June 30th. If we have the funds, then we can determine if someone's eligible for it, and we can give that assistance. LEAP on December 1 begins for those that are in a special category. You either have a disabled person in the home or you're over 60. That's a nutshell. There's lots of other things that go on with that, but that's it in a nutshell. So December, it starts a little bit, and then January 1, it is open to anyone to apply. There are no restrictions except for income limits. And so in the month of January, when I compared what we were able to process in Buncombe County as opposed to what was processed last year, we were able to process triple the applications. And so our contractor did have barriers to being able to provide certain things, and we've been able to make some efficiencies and to be able to fix some of those processes as we have brought it back in-house. That's a lot of data. Any questions about the energy program? Philip did also talk about the call center a little bit. What I can tell you is that right now we're averaging about 78 phone calls a day. Those 78 phone calls, 2/3 of those are applications. So it is application heavy. We try not to have those. We do have a direct number on the main line where they can hit the button and they can go to energy. We have our own established energy line. We do have a lot of information out there about that, so anyone can call directly to that line. They can also go online and apply if they want to, or they can come in-house. We have noticed that in-person intake is nowhere near what it used to be. When we used to have this program, which was actually contracted out in 2005, when we had this program, they would be lined up down the block in order to apply for LEAP. That is not the situation anymore. It is telephone and online. So definitely a shift in the workload and how the workload presents itself.
I have a question. So it sounds that the county took back the management of this program due to like an unforced error kind of situation where you didn't ask for it, but it just happened to, and then you took it back. How is there a process by which you review those kinds of situations where rather than Buncombe County, someone else manages? How do you know what's effectively being managed by the county versus what's effectively being managed by a third party partnership? Because it sounds like if that person was still there, that program would still be managed outside, where clearly it's better managed in-house. So how do you review those kinds of programs and make a determination that, hey, this is working well being managed by an outside entity as opposed to bringing it back in-house?
So that is actually a shift that we have started taking with my group. I actually manage quality and planning, but looking at this contract and looking at the partners and them telling us that they were not able to handle it anymore, knowing that Medicaid expansion was happening at the same time, I looked at Stony and Phillip and said, we can help. Kind of hard to take on Medicaid expansion and this energy program that we haven't had for 20 years and had no infrastructure for. So I willingly volunteered my staff to take on this massive project. But that's also what we do. But with quality and planning, part of our job shift, part of what we're trying to do is actually go and look at those really large sole source contracts that we have developed over the years. One of the things that we have historically done is if it could be contracted out and it was cheaper, we did it. We've had a legacy of doing that where this is the way we've been doing it for 20 years. And it is past time for us to be able to say, this doesn't work as well. We can do this better. We might be able to do it cheaper, those kind of things. Typically, it's come down to money. If they could do it cheaper, then that's how we made that decision. But now we have also been able to see, bringing this contract back in, we've been able to serve a much larger portion of our residents. So if we can do this better and have a better impact, a larger impact, then what else is it that we need to look at? And so there are currently on my agenda, there are 4 extremely large contracts that we're wanting to dive in deeper and take a look at and see what we've got. But that also means we have to have capacity to do that as well. And I have 8 QA staff doing energy as fast and as furious as we possibly can. So that's the plan. Stony, anything else to add with that?
No, I think that's well spoken, and we'll touch on a little bit in the budget presentation as well.
Thank you so much, Kelly, and yours and Philip's teams are doing some heroic and Herculean efforts, so thank you very much. Our 5th item on the agenda is old business, and we have none. So we will move into new business. And Stony, I am going to turn this over to you.
Okay. I'm going to share my screen, but let me make sure. Okay. Can everyone see that? No.
It's up
Yes,
now.
Stony.
You can see it? Okay, great. I just want to walk you through the budget presentation, and let me just explain a little bit about it before we start. One is our budget is a consolidated budget, much like we're a consolidated agency. So we have different, in many counties, this would be multiple budgets that would roll up into the county budget. And we present a consolidated, like integrated human services budget, although you will see it still broken down by cost centers. And that's mainly because a lot of our revenue comes from multiple areas and that are not integrated. So you'll still see a public health budget, a direct assistance budget, a veteran services budget that creates the overall health and human services budget. Also, just in terms of how the process goes, so we start working on our budget every year in the fall. So we've been working pretty steadily on this budget to craft it since the fall. And then we have deadlines to present to the county budget office around different items, such as our capital improvement requests. So anything we need to do to our buildings, things like that. We have to present our IT projects to an IT governance committee if we want to do any IT improvements. We also, if we want to request fleet or things like that, we have to create a personnel budget and then our overall budget that we present into our budget software system. So we've done a tremendous amount of work, and we're now at the point where we're ready to go to the county manager, and Lee and I and the senior leadership team will present our budget, our health and human services budget request to the manager. And then it's her job to take all the department budgets and craft a county budget recommendation to take to the commissioners. Where the HHS board comes into this process is the general statute that creates a health and human services board states that the health and human services board shall recommend a budget. So we don't have the authority to approve a budget, but it is kind of important to me that you see the budget that we're preparing as staff, so that when I recommend my budget to the county manager, it's really the Health and Human Services Board as well, that we're coming together as you as my advisory team. So I'll jump right in, and Lee's going to help me with the first 3 slides, which are really about the money. This is the bottom line. This is what we're asking you to vote to recommend today, are these financials. And then I just want to walk you through some slides that sort of explain the why behind the dollars. And while we obviously wouldn't have time to dig into every line item here, I just wanted to give you the broad budget drivers so that you can see what we're doing with the budget. And the last thing I would say is this year, every department was asked to look at their state fiscal year 23 actual spending as a baseline budget. And you'll see some inherent challenges in that, because that was 2 years ago, and the cost of doing business has risen dramatically in the last 2 years. But we did start with that base. So when you see our increases, I just want you to realize this isn't an increase from this budget year that's about to end. It really would be an increase over our final spending from 2 years ago. So just with that caveat, we'll just jump in and start talking about the actual numbers. And Lee, I will turn it over to you for this slide.
So, as you know, we have quite a few position requests, and so in this is showing all of our position requests, the salaries and benefits. So that's why these numbers look really high. And then they're obviously, when we get through, as the county manager recommends budget, we'll find out that probably not all of the 45 positions we've requested will be approved. It's a large ask this year, but a lot of it's due to bringing the community assistance team back open. So we need to fully staff that, because right now we're borrowing positions from other departments. So requested that for FY25. It also includes the asks. Some of our single source contracting have asked for some large increases. Animal services had a large increase over the past 2 years. They had a large increase last year, and then they had a big ask this year. So, and we're also looking at what we recommend versus what they're asking for, and see if there's some negotiation in that. So, and you'll see that probably on the last slide we're going with what we're recommending. So, like I said, a lot of these, the increases in the salary and benefits. In direct assistance, we had a lot of increased costs because the foster care board rates went up. So a lot of that's just out of our control. It's part of doing business since the rates have been raised. And also it's skewed a little bit because we didn't really have SIP and LEAP in 2023. Health is pretty much staying pretty good. We do have some loss of revenues around COVID dollars. A lot of those AAs are ending, so we have a little bit less revenue coming in. Veteran services, the same. Next slide. Study, can you advance the slide?
Oh, I did. Is it not showing?
It's still on the budget summary for
Hang
the
on.
slide 3.
Oh, it's advancing on my screen. Hang on a second. Let me see if I can figure out what's going on. So you are not seeing it.
No, I just see the slide 2. I see your cursor move.
All right.
Can you just try clicking on the slide and see if it does that? There we go.
Is it showing now?
Yeah.
Okay.
So recent trends in headcount, we've really stayed flat with FTEs over the past few years. And I think because of us needing to bring in, obviously, the community assistance team, we're also wanting to bring in the visitation team, which is another large ask. So a lot of these positions that used to be, they were contracted services are now showing up as FTEs. So that's why we have quite a large ask this year. And as you'll see, the operating expenses, it's staying alive for FY25, but our actuals as we're going through the year, we're on track. But as you see, like a lot of those COVID dollars are not existent anymore, a little bit. But our budget has pretty much stayed the same, so rather flat. The next slide on recent trends is for mainly because of in revenues for social services, we had an increase of 1.9, mainly in Medicaid, which is uncapped revenue. But also in the budget, there's a decrease in FY24. That was the actual for FY23 was the increase of the 1.9. But for FY24, a decrease of 2.2 million, mainly Medicaid due to we have a lower reimbursement rate for certain overhead and indirect costs where it used to be 75% and now it's 50%. And we lost the loss of the hold harmless funds for DSS. For health, in FY23, there was a decrease due to loss of AA funds in the school nursing and health promotion. But in FY24, expected the Medicaid cost center to decrease because of the managed care environment, and it did not decrease like we had expected it to be. So we are budgeting more for that in FY25. So you can face the next slide.
Okay. And now I'll take over and sort of describe the story behind the numbers. I think that, as Lee said, a large part of our budget increase really is around staff. And I think it only goes to say that in a human services agency and a health agency that serves people, our greatest tool and resource are the people that serve the people. So our personnel ask this year is really driven by things that you've already heard of in this meeting. It's just an incredible increase in caseload growth. It's taking in, large programs that we had contracted out for 20 years. It's continuing to look at that, as someone mentioned, around maybe some contracts we've had for quite a while that are struggling a little bit to meet some of our core mandated services and the need to continue to bring some things back in-house for the benefit of our client. And some of it's just right sizing around HR personnel kind of issues. So the first one we've talked about is this community assistance team. So this is the team that next year we'll have a permanent team that will run all of our energy assistance, our crisis assistance, our general assistance, our mortgage homeowner grant program, rental assistance as long as it lasts. These are sort of what I would call, our safety net kind of services, crisis safety net services that our Beacon group in the community operates. And so this team will be a multifunctional team. It won't just be energy. And we would be calling this our community assistance team. and we would need 15 total positions if you count temporaries. The county actually budgets those differently. So if you take those out, it's really 9 positions, and we're hopeful that actually we'll be able to do it with that. We're already evaluating that because the numbers, we built this back in October, remember, or December when we took it back, and the numbers have been much higher than what we projected. So we'll have to keep an eye on that next year as we move forward. The second ask you heard about was with our call center. And as Philip said, call center would suggest that it's more like a reception service, but it's really not in our county. Our call center is truly a service center, and we can do much more for people when we classify these positions as caseworkers. And it's really just numbers. We'll add at least 10 to 12,000 Medicaid recipients, if not 15, as the state projected. We'll add 10,000 new energy clients this year. So that's going to be at least an additional 20,000 new clients that will be calling us, not just once a year. And it's really just math. Our current call center can't handle that kind of increase. So we're just trying to adjust to our nurse service delivery model and our caseload need. The next thing we want to do is we've been contracting out for child welfare visitation for quite some time, but this has really grown to be a very demanding program for our contractor to deliver. And if you look down in the left corner, sort of at the bottom of that, it just shows you how many hours, how many children that we supervise visits for each month. And it gives you the total number of hours a week there. And you can see it's anywhere from 240, 235, as many as 308 hours a week of court-ordered supervision. And this is not only is it a core mandated service, but it's required by law. So at one point this year, we got down to 1.5 contract staff to provide these services, which of course they couldn't do. And so that puts a burden on our foster care staff, because then we have to pull them out of the field to supervise visits, and then there's no one to go visit the children, which requires our staff to work overtime. And it becomes somewhat of a challenge in lots of ways. So we're promoting that we bring this back internal this year and have these staff be our staff. And we have built a family visitation model at the Grace Center that really works, which actually allows a visitation coach to supervise more than one visit at a time. So I applaud Rebecca for creating a very effective and efficient system, but we feel like it's time for these staff to actually be county staff. The next one is in environmental health. We've been growing the environmental health section each year. We've added a couple of positions a year now for a few years. And we just need to continue that because we've done a workload analysis that suggests we're still 6 inspectors short. So we have sort of a long-term goal of just adding these positions each year until we get to where we need to be. And Ellis could attest to this. We have a lot of restaurants in Buncombe County. And when you add to that pools and wells and nursing facilities and tattoo establishments, we do a lot of inspection, and these are all, of course, required by law. And not only do we have a lot of inspections, but we have a lot of what are called level 4 restaurants. These are restaurants that do more creative cooking, and so it requires more visits. It requires a little more oversight. These are like restaurants that might be aging their own meat and things like that. So we need to be sure that our community is safe, and we quite honestly just are a little understaffed in this area. So we're asking to continue to build this each year. And then we get into, someone was asking about these sole source contracts. So what Kelly said is true. We have several large sole source contracts. And by that, I mean the contractor is providing the entire service on behalf of the county. And these will be our contracts like animal services, school nursing, child support enforcement, child care subsidy, and up until this year, it would have been our energy programs. And that's worked very well for Buncombe County for a very long time. But over time, we've lost a bit of our subject matter expertise in these areas. And what we've realized is that we still need to be on site from time to time as subject matter experts, ensuring that the quality of service is what we would expect if we were doing it ourselves. So what we're proposing is to build our QA staff a little bit so that we can really be hands-on in these sole source contracts and be on site more, do more professional development on our side and be a partner, a better partner to our contractor. And so we're asking to add one in social services administration that would look after our child care subsidy contract, would do child support, would also be able to do internal QA on the energy program now that it's back. And in addition, we obviously have more QA needs in Medicaid now that we've added so many more Medicaid clients and Medicaid staff. The other QA specialist we'd like to add is around public health and administration, environmental health. And that team is growing. And also the state has moved away from a system where your enhancement dollars used to be based off of how many inspections you did a year, but they're moving to a system now where it's going to be based off quality assurance. So we could help out, get ahead of that process. We also could take over our animal services contract, sits in environmental health, and we could be more involved in that space as well, just more as subject matter partners rather than funding partners. And then the other QA position we'd like to add over time is just in our public health administration around more of our clinical and what I would call our community health programs, like WIC, school nursing, family nurse partnership, care management. Most of these are Medicaid programs or USDA programs outside of school nursing. And so it would allow us to also be providing QA for these contracted services and some of them internal. The next area is just START team. This is really a pilot for the county. One of the strengths of our START team is peer supports, and the county is looking at maybe establishing. We contract all our peer support out in the county, whether that's at HHS, Justice Resources, the paramedicine team through EMS, and even through our syringe services program here at HHS. So we begin to ask ourselves, should these peer support counselors really be county staff? And we're not really sure as a county if it's time to do that, but we've talked about maybe piloting that process at HHS through the START team, and we were actually doing peer support first in the county, and we've certainly volunteered to run that pilot if the county wants to do it. And this would be what it would cost us to do that, to bring those folks in-house. It's about $140,000. Moving on down, some of these are probably, and I'll show you in a minute, lower tier requirements, but we also have a contract child and family team facilitator, the same thing. We're wondering if we shouldn't bring that in because of the sensitive nature of the work. And then our breastfeeding program, every year we win national awards for this. I think we're actually received the highest award possible now. And we'd just like to expand it a little bit. We'd like to keep reaching more mothers in our county to support breastfeeding. We believe, obviously, from a public health perspective, we believe that's better for children and mothers. And so we're just asking for half of a position so we can just grow it a little bit. And then the last one is really about just bringing an immunization nurse from contract to full-time. And this is actually a nurse that the board recommended we add last year when we rebuilt our travel clinic, foreign travel clinic, after COVID subsided and people were starting to travel again, and we were getting more requests to do travel immunizations. And we've rebuilt that program, and it's going well. And we've just run it with a contractor up until now. But since we're going to keep it long term, eventually we'd like to just bring that back into our regular personnel and our regular immunization staff. Our mobile team request, the mobile team is going amazing. Ellis and I talk about it a lot. I think it's one of the most exciting initiatives that we have, and there's so much potential in the future. I love it. It's community based, it has a strong equity component. But we actually have secured another year of grant dollars through DPH for this team. So this team is already running, but eventually we'd like to move them out of the grant budget and back into the HHS budget where we feel like they most likely belong. But for one more year, we're going to keep this team in the grant budget because we do have a grant to cover it. And next year, you'll probably see this as our top priority for positions to bring into the budget. So one of the things we do when we go to the county manager, as you can imagine, everyone's asked to bring their best and highest budget. If you're going to have maximum impact, but there's not always, like any budget, there may not always be enough money for each department to do that. So we begin to put our priorities into tiers to help the county manager if she has to make decisions, and we can't fund everything that every department asks for. So just want you to see how we have tiered our priorities, and we sort of do it based off core mandated services. What must we have to serve our citizens, and then they're all important, but we do tier them. And next year we feel like our top priorities would be our security enhancements in our building. I think we've talked about that at some time. That's a capital process. And we've had, unfortunately, way too many security incidents last year where staff have been at risk or visitors have been at risk. And we have a plan that's been approved by our county security officer to change the structure of 40 Cox Avenue a little bit to make it much safer for both staff and visitors, of which we have about 65 to 70,000 a year. So a lot of people come into our building. We've also brought all our services in there now. So a lot of those security incidents were spread out last year in multiple places. We've now brought all that into one single point of entry. So to me, this is really my top priority. I've got to know that my staff and my visitors are safe when they visit our building for services or to work. The next priorities you've heard of, the community assistance team is a top priority. We will not be able to do this work if we don't add some staff to do it. The social work visitation team, the call center, and the environmental health specialists are what we're listing as our top priorities. Those are all direct service. I believe that if we don't add these positions, we will not be able to serve our community effectively. And that's how I always begin to think about top tier. Our second tier priorities, you can see, are around more organizational administrative functions. And these are the QA positions for next year. We thought 2 would be our second tier to start there. That reclassification of a social work field supervisor, we were asked to put that in there. That's actually a separate project that's a little bit related to our retention and right-sizing our social work HR structures. So that actually will be handled in a different way, but we put it in here as priority. We also want to increase our HHS fleet. For those who don't know, our food and lodging inspectors do not have one county car among them to do the visits. They drive every day to restaurants. Our social work division has 7 vehicles for 150 staff, and everyone drives their own vehicle. And we've done a pretty extensive study with our strategy innovation department across North Carolina, and they're recommending that we build a fleet at HHS. So that's actually coming out of our strategy innovation department. We certainly agree with it. There's been some county commissioner interest in building a fleet for HHS, so that's a priority as well. The family mentors I mentioned, which would be a pilot project for the county, and then to upgrade our bathrooms in 40 Cox Avenue. Unfortunately, due to the age of the building, our public restrooms were built many years ago, and they're not ADA accessible. So we'd like to upgrade those. We don't have to by law. We should do it because it's the right thing to do, and we serve a vulnerable population. So that's a high priority for us as well. And then our third tier priorities are really to build a separate standalone veteran services suite in our building, to continue to add environmental health specialists. And of course, we're keeping the public health mobile team. This year, it's not a top priority, but we like to keep it front and center. And then next year, it'll move to the top. I just want to show you the fleet. Mentioning the fleet, this is what Strategy Innovation has requested. They're actually recommending that all of our food and lodging staff have county vehicles, and that we build our social work team by 12 vehicles a year, and then they start rotating out. And you can see how the money works out at first. At first, it's a county costs, but over time, when you look at the amount of mileage that we're paying, you start getting revenue neutral down there. And that, what is that, 1, 2, 3, for fifth year. And then that grows to where we're actually saving county dollars over time. So we'll certainly would like that for financial reasons, as well as just for the benefit of our staff. And also, quite honestly, I feel like it can be a liability issue, especially if we're transporting clients that perhaps it's not a good idea to be transporting them in private vehicles. Those should be county vehicles. I also want to say a couple of our drivers, Lee mentioned it, and I'm not putting them all up here, is our contracts. So when you look at a large increase from fiscal year 23 to 25, the cost of doing business has risen for everyone. And when you have a large single source contract who has a lot of staff and a lot of supply needs and those kind of things, their costs go up just like ours. And that drives our budget. So I just put a couple on here so you could see sort of what happens. This is animal services. And we have also done a strategy innovation study on this. And it's still a better cost to the taxpayer. If we were to set up a standalone animal services department in Buncombe County, it would cost much more than this. But you can see the increase over 2 years is going to be, $500,000. And school nursing is much the same. I'm proud to say that Mayheck had a year this year where they had no turnover in school nurses from July to February. They had their first resignation in February. And so the program is going well. It is really leveled and is doing well. I understand morale is good. And we're very thankful for that partnership. But their costs are going up too. So you can see in 2 years, it's gone up, in about a 650,000. So again, these are fairly large increases, but they're really around staffing cost. A big part of it's around staffing costs. And we're also proud to say that right now, I believe there's not a school, Ellis, you can correct me, there's not a school in Buncombe County that doesn't at least have half a nurse FTE. So we have no situations where a nurse is serving more than 2 schools. And all of our middle schools and high schools have a single nurse, which is certainly best practice. And then Lee mentioned this too, and I just show this as an example. Part of our cost of doing business is things change at the state and federal level for which we have no control over. We don't necessarily disagree with them, but it ends up as a county cost. And this one just shows you how foster care board rates, and we're happy for this. Foster care board rates have increased in the last 2 years to foster parents, and boy, was that way overdue. We're now providing kinship assistance to family members who may not be licensed as foster parents, but they're caring for children who are in our custody, and now we're able to pay them a stipend. It feels really good, but there is a county cost to that. The Special Assistance In-Home Program has a mandated increase every year based off the Social Security increase. So these kind of things go up, and they're to serve our vulnerable population, but there is county cost attached to them because the federal government and the state does not pay the full cost. It's a county state match. And so whenever these rates go up, our costs go up. And then one thing that is a true expansion this year, I guess, that we're promoting, I want to make the board aware of it because we're extremely pleased with it. And Rebecca could report on this in more detail. But we have a partnership with ABCCM as in child welfare, and also it's a part of our substance use disorder service continuum in the county, where we purchase 12 beds a year at Transformation Village. And we're able to allow mothers with substance use disorder to go there and keep their children with them. So in most counties, those children will be separated from their mothers. And unfortunately, just from many years of experience, a lot of those children never go back home. But we've had tremendous success in this program. I mean, I think the Transformation Village model works really well. We're not the only person they serve. But those 12 beds have been an amazing return on investment when you look at social capital and really impacting the next generation. So we're not just providing good services to a citizen with substance use disorder, but we're impacting their children and keeping that family whole. We're really, really high on this program. But you can see we want to expand it next year. We want to see if we can go from 12 beds to 16 beds or to 20 beds. And so we'll be taking this to the county manager with the request that perhaps we expand these services. And maybe there's even a possibility we could use our opioid settlement dollars to do this, because it's in line with the with what we're trying to do with those dollars, which is around supportive housing. And then also just wanted to close with this, and Lee might want to comment. If the county manager were to look there, we like that. We put our best and highest budget up first. You saw it. But if the county manager were to say, I'm going to go down to your first tier, that's the best I can go. We like to give options. We could do it first, second, third tier, but this would be what the budget would look like with our first tier options, which is, as the county's public official in charge of health and human services, I feel like we cannot go any lower than that tier next year and provide adequate services to our community. Then this would be the budget increase that we would be proposing to the county. So we always want to be fair and present things for multiple options. I realize the challenges of balancing a budget as large as Buncombe County's. So in light of that, I'll stop sharing and I'll open the floor for discussion, and then I would ask that the board make a recommendation, maybe a motion, a second on a recommendation to approve the budget that staff has prepared.
Questions for Stoney or Lee? Seeing none, I will entertain a motion and a second to approve the proposed budget as presented by Stoney.
So moved.
I'll move. Or I'll second, whatever.
Okay, so Amy,
We're
I saw
all
you
in.
first. And then Steve. Yes, I guess we are all in. All those in favor, please indicate so.
Aye.
Any opposed? All right, so the proposed budget passes, and wishing you success, Stoney, presenting that.
Thank you. And I'll move on.
So, yeah, go ahead, Stoney.
Yeah, I'll just move straight into oath of office. And I want to say that today I'm not asking the board to take any action. I really just wanted to bring this as a point of discussion. And but I ask that it be under new business, because really it's a decision that the board can make. And so maybe next month, I'll send you more information after today. The board could take a formal vote on where you would like to go with this. So I'll just give you some background. In North Carolina, and we talk about this a lot, and I'm happy to say that Christy Nicodem, who is a professor at the School of Government, an attorney, and she specializes in consolidated health and human services. She's coming out with a consolidated board handbook this year. And I promise you, as soon as that happens, we will purchase a copy for all of you. And I think it will be a tremendous resource, because we often have to look at what consolidated health, we often look what traditional public health board responsibilities are. We have to look at what traditional social services board responsibilities are. We try to have to marry that into the very small consolidated law, and it leaves sometimes things up to more opinion than statute. So oaths of office are one of these. So in North Carolina, if you're a public health director or you're a social services director, you are required to take an oath of office. But consolidated directors, it's always been, no one's really been sure about that. It's the same thing for boards, for public health boards, for social services boards. But by statute, you really carry all the responsibilities of a public health board and a social services board, as well as some county responsibilities, because we have services besides those two in our agency. You do not necessarily qualify as a public official. You're really appointed by the county commission, and they all take an oath. However, the legal advice out of the School of Government is that all consolidated directors and all public health directors and all public and DSS directors in a local consolidated agency take an oath of office. So Ellis and I have both taken an oath of office. And it does provide some immunity from civil lawsuit. So there's a legal side as well as a statutory side. And the School of Government's recommendation is that every consolidated board member take an oath of office, although there is no case law that would say that it's required. I also serve as the chair of the Consolidated Human Services Alliance in North Carolina, which is made up of most of the consolidated counties and the directors from those counties. We talk about these kind of things all the time, and we did a poll recently. I was going to share it, but in the interest of time, I'll just maybe get it to you. But in that poll, we asked, one of the things we asked was the question, is your board take an oath of office or do they not? And just to give you a little bit of data, I think, let's see, I'm trying to pull it up to make sure I am giving you the absolute right. About 2/3, I'll just give that, about 2/3 of the counties who responded, and it was most of the consolidated counties, have their boards take an oath of office. Their board chooses to take an oath of office. So today, I really just wanted to introduce the topic to you. In the next month, I'll send you some posts, some blogs from the School of Government. And then I think that the board should really decide where you're most comfortable. And then we'll build it into our board operating procedures, and we'll move on whichever way that you decide. But we've really never thought about it too much in Buncombe, because when we first consolidated, we just the choice was that we wouldn't. And I think the opinion today, 10 years later, is that it's probably okay. Kurt is on the call, I believe. He and I have talked about this. He's told me that it is not legally required. No board member has to take an oath of office. And that's why we feel like the board should decide what your operation or procedures will be. And then as staff, we will support that. So is there any questions I can answer today? Like I said, I just wanted to introduce the topic. I'm going to send you some information out. And then next month, I feel like we probably should make a decision one way or the other. Or I guess no decision would be a decision.
And I just wanted to just make one thing. So the chances of any board member being sued individually is slim to none. Obviously, I can't say it's 100% because you can sue anybody for anything, but you all act as a board. So any decision that you make or is challenged would be based as a board, not as an individual member. So the idea of you having, let's say, public official immunity is not, I think, as necessary as it would be Stoney, for instance, or someone else who's actually having to make certain decisions by themselves that someone might say they're violating the Constitution or other things. But your case, as a board member, you are basically acting as a collective and not as an individual. So I don't want anybody to stress about liability or increased liability by serving on this board. But I'm happy to answer any other questions. I agree with what Stoney says. Unfortunately, the law is just unclear, and it doesn't hurt, but it's not necessarily a mandatory requirement either.
I would say personally, if the law is unclear, that we err on the side of caution.
Thank you for that, Jacqueline.
It's not going to cost us anything but a little time.
No.
And we will continue this discussion at the March meeting before voting. Anything else, Stoney, that you have?
No, Lucy, and that's, I think, all I had in my director's report. So I will turn it over to you to wrap us up.
Okay. Well, I only have a couple of things to say. I would like to welcome our guest in the meeting today, Claire Hollowell, who is a senior undergraduate student at UNC Chapel Hill. And Claire is studying health policy and management and writing her senior honors thesis on Buncombe County's approach to the opioid settlement funds. And I encouraged Claire to reach out to Dick and to Ellis with any questions that might arise and help in terms of finishing her senior thesis. So congratulations and thank you for being with us, Claire. Martha Salyers, Amy Linnell, and Stephanie Bostic all agreed to be on our Land and Labor Acknowledgement Ad Hoc Committee, and that group will be meeting next week and will determine whether they will invite community members to participate in that ad hoc work. And then I just want to remind everyone to please reach out to your friends and neighbors about the vacancies that are on our board currently. We have the open position of dentist and the open position of engineer. Both of these are required by state statute for our HHS board. So please give strong consideration to who you know who would be a great fit for our board. Is there anything else for, as Stoney would say, the good of the group? Yes, Elizabeth, I see you.
So I believe that in 23 days, if the news articles are correct, in 23 days or so, we will know whether or not Mission is going, whatever is going to happen with Mission. I'm not so sure what the ripple effects are if that were to happen when it comes to the board. But maybe, so my question is, if something does happen to Mission, is there a way to discuss, I don't know if the Buncombe County commissioners are the ones who are going to be involved. I've never lived at a place where a hospital has closed down, so I do not know what that means in terms of the Health and Human Services Board. So it's just a conversation, whatever that is, if it does happen.
Stoney, you want to take that?
Nobody wants that.
I'm going to defer to Kurt.
Elizabeth, good question. I know that the county, we are monitoring that in terms of an emergency response. We've definitely had numerous issues between the county, our EMS services, and the Mission's ER department. In addition, the HHS department has a relationship with Mission regarding the morgue. They are our morgue and the storage of bodies. And I also have to say that the county also has filed a lawsuit against Mission Hospital and Team Health, HCA and Team Health. So if something does happen, it will affect various different things. And I think the best thing we can do is alert you and alert the board. And then you all can make a determination as to whether you need to meet. Because really a lot of what's happening right now, at least from what it appears to me, is whether Mission can continue to get Medicaid dollars, Medicare and Medicaid dollars for the services that are provided at the hospital. And if they get that poll, they won't be able to collect on that. So that's what my understanding is, that at least with the federal government right now, that's the issue as to whether they're going to be able to get that, whether that gets pulled or not. it doesn't necessarily close the hospital, but it would definitely affect their finances.
Dan, your hand is up.
Yeah, just I don't think we need to worry about the closure of a hospital in this time frame. There's a lot of stuff happening, of course, but our region did experience what happens when CMS pulls their funding with Haywood Hospital.
That's right.
That happened. Haywood did not close, I mean, they suffered through it. A hospital will suffer tremendously financially because of this. And if that were to happen, which I find it highly unlikely for it to happen, then HCA has two choices. They either sell the hospital or they fix it and put their own money into it and go through that process. And so Dogwood's fundamental responsibility is, if the hospital is in a state of selling, Dogwood basically has first dibs to buy it back. So just keep those things in mind. This is not, there's a lot of possibilities, but it would be unlikely for the hospital to close.
Thank you. Thank you for that.
Thanks for bringing that up, Elizabeth. If there is no further discussion or conversation or questions, I will take everyone's approval to adjourn by signing off.